Hello, my name is Adeline Maycan, and I would just like to thank everybody for viewing my presentation. So today I'm going to be presenting my capstone case involving the psychosocial implications of traumatic brain injury. The brain is the most important organ because it controls every part of the body and every thought, feeling, and action. This quote is certainly applicable to this case because we are going to be examining how a structural injury to the brain can impact mental health and behavior. In the first half of my capstone presentation, we are going to be reviewing how I completed assessments with the client, how I conducted research to formulate evidence-based interventions, and how we applied that to the treatment plan, and of course, evaluation of results and progress. So just a quick overview of the internship and case setting. So the current case took place at the Behavioral Health Clinic at the Walton County Health Department. So the intern role, my role, consisted of seeing behavioral health patients with the supervision of a LCSW licensed clinical social worker. The intern provided supportive mental health services, advocating for patient needs, providing resources, and administering and scoring behavioral health assessments. This internship took place over the course of fall semester from August to December. So let's go over the demographics of the client that this case is based around. So I first met the client, as we're going to refer to him as Mr. Sawyer, in August when he first arrived at the agency to begin the intake process for behavioral health services. The client is a 65-year-old white cisgender male. Mr. Sawyer is not religious and has strong values of resilience and self-efficacy. Mr. Sawyer began reported symptoms of anxiety, anger, and irritability and isolation following a traumatic brain injury. So the client was referred by his primary care physician to the behavioral health clinic for behavioral and psychological assessment regarding presenting problems of anger, irritability, and anxiety and isolation. The physician's rationale was the post-secondary TBI symptoms of the client. These began approximately 4 months following the client's involvement in a motor vehicle accident, resulting in a traumatic brain injury. So ethical engagement in social work practice was conducted through the confidentiality establishment and client self-determination. So I reviewed limits of confidentiality with Mr. Sawyer. This included disclosure of suicidal intent, disclosure of harm to self or others, and disclosure of neglect or abuse. So I also created a therapeutic environment conducive to Mr. Sawyer's physical, emotional, and psychological needs. This included breaks for the client during sessions, a sound machine to support confidentiality, and appropriate lighting to reduce risk of headaches. Clinician reliability and open communication. So proper notice of schedule changes and cancellations for weekly sessions was always with great advance notice. So per Mr. Sawyer's approval, there was a collaborative treatment approach with the interdisciplinary team. This included physicians, nurse case manager, LCSW, clinical director, and MSW intern, which is myself. The next piece of engagement is the setting and client readiness. So this setting was a health department where subsidized supportive sessions were available at a community level. Support was based on barriers of financial resources, and then I was involved in advocacy to reduce barriers, including virtual Medicaid consultations with external experts to connect clients to those resources, and then values and client-based engagement. So I focused on cultural competence with my clients, the client and environment, a perspective and framework, and then building interpersonal rapport with the client. So there was a recognition of Mr. Sawyer's strengths and values in the engagement process, and then the treatment approach was informed by Mr. Sawyer's worldview, unique experience, and values. The next piece of engagement is building client motivation. So challenges and goals for the client. The traumatic brain injury impacted the client's memory, vision, and emotional regulation. The client had a marked desire for improved interpersonal relationships, emotional regulation, and the cognitive implications of his injury. Mr. Sawyer continued to participate despite these barriers. The advocacy and support. So whenever the client's needs extended beyond my expertise and the LCSW's expertise, there was a referral to community resources, and Mr. Sawyer's readiness for change was definitely contemplative. He was ready. He wanted to change. So now I'm going to go over the assessment approach. This was a multidisciplinary approach where we began with a strength-based perspective, which was a focus on client resilience and desire for change rather than focusing on client pathology. So my role in treatment was to use empathy, rapport building techniques, and professional use of self to foster client engagement, and building the therapeutic alliance, integration of client values and culture to enhance rapport and build that alliance for change. So the next piece of assessment is presenting problems and referral rationale. So the presenting problems was due to the traumatic brain injury. These were migraines, cognitive impairment, memory issues, anger, anxiety, and isolation. The referral to behavioral health was by a physician due to complications from the traumatic brain injury, and then history of presenting problems. The incident of the traumatic brain injury occurred during a motorcycle accident where the client was riding a motorcycle, but at the same time, the client was also going through divorce, which stimulated significant psychological stress. So psychiatric and medical history. The client has no history of psychiatric illness, but there is spinal nerve damage due to the injury. And then substance use. The client has experience with dealing with alcohol use, cocaine use, and marijuana use for pain and stress, but no current use of substances during treatment was indicated. So the next piece of assessment is the mental status exam, assessment of presenting symptoms, and then treatment planning. So the mental status exam begins, we look at appearance and behavior, self-care routines are present, the client has good hygiene, clothed appropriately, the client has open and honest behavior and communication, cognitive, normal intellectual functioning, difficulties with memory and recall and thought process, and then mood and affect, reported mood shifts, no signs of psychosis or delusion. And then assessment. So the assessments utilized to measure these presenting symptoms during the intake process was the DSM-5 anger and anxiety screeners, the UCLA loneliness scale, and the affective reactivity index. There was severe anxiety measures, moderate anger measures, severe loneliness measures, and then high emotional reactivity. So the treatment goals here are going to be to mitigate secondary symptoms of traumatic brain injury through supporting and facilitating emotional regulation, increasing socialization, and improving coping skills for anxiety and anger. So now we're going to go into the case interventions. So the treatment plan. Complex needs require nuanced solutions. This is a nuanced case. So there was a heavy research involvement. There was a reflection on my role and my competence, how I can help the client. So we ended up taking a multifaceted approach, including neurological, behavioral, and emotional needs. So the treatment plan structure, weekly 1-hour sessions with me and the LCSW, targets, memory, anger, anxiety, irritability, and isolation, interventions, advocacy, client empowerment, supportive sessions, and referral to neurological care. And then client empowerment. Self-determination through active involvement in goals and objectives to create a research-based sustainable treatment plan. So the next piece of interventions is client goals. Goals establishment is a key factor in therapeutic outcomes. Goals are subjectively desirable states of affairs that the individual intends to gain through action. So his goals were to improve interpersonal relationships, develop coping skills, memory management strategies and tools, understand the traumatic brain injury through collaborative psychoeducation. So following goal establishment is establishing objectives. Objectives are actionable steps that are specific to enhance goal attainment. So for the first goal, the objectives were to examine family dynamics, build trust, and practice calm responses during interactions. The objectives for the second goal were to understand mood disruptions through traumatic brain injury education and practice weekly coping strategies. The objectives for the fourth goal were to develop and practice memory recall strategies. This involved using a daybook to log activities, watching familiar movies. This helped the client kind of recall those familiar actors and names and characters. And then the objectives for the last goal are to review psychoeducation materials, create reference materials to take home, and after sessions, the client would collaborate on a long-term neurological and behavioral management plan with the entire interdisciplinary team. One of the most integral steps in the interventions stage of treatment is looking at evidence-based strategies and interventions. So what has proved in studies and research to be effective for treating behavioral manifestations of traumatic brain injury? This literature and evidence points to an integrated approach. So the first thing is to build coping skills. This is done through psychoeducation, social integration, and supportive psychotherapeutic techniques. Evidence also points to cognitive behavioral techniques as being effective for reducing anger, depression, and anxiety, altogether improving coping skills. And then also a strength-based approach, addressing frustration and depression through enhancing self-efficacy. So continuing on what the evidence says. So positive self-appraisal is an important piece here. So increasing self-esteem in the client, reducing depression and enhancing coping skills, and then social integration. It's important to support interpersonal growth and boost life satisfaction in the client. And then there's tremendous education on the benefits for individuals with traumatic brain injuries and concussions for using holistic techniques such as aerobic therapy, omega-3s, caffeine, and acupuncture for insomnia. So what theories support the actions taken during the interventions process? So overall, the approach followed a multi-dimensional approach, which uses a range of techniques from multiple approaches to inform and address interventions. There was also the cognitive behavioral model was applied, which focuses on modifying thoughts and behavior to increase coping effectiveness. The ecological model played a role here, consideration of client beliefs, attitudes, and behaviors along with context of the environment. And then also the biopsychosocial model, which assesses needs holistically through the consideration of biological, psychological, and social factors. So to measure client progress and evaluate client progress, there were 4 screeners and measures introduced. These were the DSM-5 Level 2 Adult Anxiety Screener, the DSM-5 Level 2 Adult Anger Screener, the Affective Reactivity Index, and the UCLA Loneliness Scale. So why choose these measures? The DSM-5 Level 2 scales for anger and anxiety trace physiological, cognitive, and emotional aspects of anxiety and anger. Traumatic brain injury is often accompanied by anger and anxiety, making this a critical tool for measuring symptoms. So the Affective Reactivity Index traces mood changes and emotional dysregulation. These are indicators of traumatic brain injury and are client presenting problems, making this tool essential for measuring symptoms. The UCLA Loneliness Scale. So loneliness was a client-determined presenting problem and is characterized as a secondary symptom of traumatic brain injury. Therefore, this scale is relevant to the measurement of client symptoms and behavioral health progress. what was the evaluation design? So the evaluation design was a non-experimental design with recurrent tri-weekly measurements over an 18-week treatment plan. The data was collected using a collaborative approach between the client and I. The client needed assistance for reading assessment questions. This was just to prevent headaches. And then I scored each measure according to its respective clinician instructions. The multidisciplinary treatment approach was evaluated through these regularly structured assessment intervals. So the evaluation rationale. The evaluation seeks to measure improvements in anxiety, anger, irritability, and loneliness in the 65-year-old client, Mr. Sawyer. The recurrent stratified screeners allow progress to be monitored often enough to measure changes over time, but with enough time in between assessment to allow the client to participate in client-led sessions. The client struggles with completing assessments due to his traumatic brain injury. Therefore, I developed a stratified screening approach, which would be more conducive to the client's overall needs. So the next few slides are the tables and figures of the current case. These are just going to be graphs displaying assessment data and progress. So this first one is the data from the affective reactivity index. So you can see we have improvement over time here. So this graph displays data from the UCLA loneliness scale. You can see client progress here from the beginning to the end of treatment. Here is data from the anxiety screener. You can see here there's also improvement over time. And our last graph regards the anger screener, and you can also see improvement over time. So let's discuss these results and look at client progress. So for the affective reactivity index, there was a decrease in symptoms by 12% from week 1 to week 18. For the UCLA loneliness scale, there was a decrease in loneliness by 11% from week 1 to 18. For anxiety, there was a decrease in symptoms by 16% from week 1 to 18. And for anger, there was a decrease in anger by 11% from week 1 to 18. So we made progress. The client established an evaluation goal of improvement in symptoms within 4 to 6 months of treatment. This goal was achieved. The multidisciplinary, multidimensional approach led to decreased symptom severity across all targets. So in research, when we're discussing results, we want to also look at some alternative explanations. So these alternative explanations primarily come from research studies and other evidence. So research points to socialization as a factor for explaining progress. So socialization really decreases overall symptoms, improves well-being, and then neuroplasticity. The brain is always adapting to new stimuli, injuries, and so forth. And then treatment of loneliness. This kind of plays into socialization. Socialization and the collaborative interdisciplinary approach taken with the client really helped to mitigate some of that loneliness, which increases overall well-being from a behavioral health perspective. And then anxiety as a compounding factor. Treating anxiety really does help improve overall well-being of the individual, which could account for some of that progress. So what are some established agency-specific evaluations already in place? The Florida Department of Health conducts an annual report on public health. This includes a very small portion in the report regarding behavioral health. And then also the Florida Department of Health uses a behavioral risk factor surveillance system. This is a survey that the Florida Department of Health conducts with its census just to evaluate where behavioral health is at in the populations being served. And then, of course, at the clinic, there is a little post-session exit survey, but based on my reflections and my understanding of the literature regarding evaluation standards, as well as agency standards and academic standards, I don't think that these agency specific evaluations are sufficient for measuring client outcomes. So the agency's methods were not sufficient based on, like I said, my knowledge. Research suggests that an improved model of assessing the quality of mental health services includes an evaluation of service relevance, accessibility, acceptance, engagement, clinician competence, continuity, efficacy, and safety. And the clinic survey did not encapsulate dimensions of accessibility, acceptance, engagement, or competence. Therefore, I'm just saying that these evaluation measures are not sufficient. So now we've come to the second part of my capstone case, where we're going to be going over a reflective synthesis of social work ethics, human diversity and social justice, and policy competencies. So the first portion of the reflective synthesis regards ethical dilemmas and ethical practices. So the issue that the ethical dilemma that we're exploring, the client engaged in behaviors that crossed professional boundaries. This included the presentation of gifts to certain staff and staying after session and interdisciplinary meetings to socialize with the staff. This dilemma really challenged my confidence in the therapeutic relationship. However, I was able to address this issue through addressing Mr. Sawyer's feelings of loneliness and his desire for social support in session. And then the LCSW informed the client of my professional boundaries to reestablish boundaries and expectations in treatment. So in an ethical dilemma such as this, it's important to understand discrepancies and similarities in values. So some core values at play in this case are service, social justice, dignity and worth of the person, integrity, and competence. So my personal values as a professional is to uphold ethical conduct, clear service expectations, which involve payment for services and not using gifts as payment for service. And then, of course, upholding integrity of the helping professional relationship. So discrepancies here, I have a huge value of self-reliance and being independent and trying to solve problems on my own versus the NASW's emphasis on collaboration and interdisciplinary consultation. So some similarities: payment for services, ethical conduct, and integrity. This is where I am very congruent with my professional values. I uphold these and I want to maintain professional boundaries. So the next piece of the reflective synthesis is looking at human diversity and social justice in the field. So in this case, how does power and oppression play a role? So this was addressed through the agency for resources and treatment access, and then countertransference. So the client's behaviors caused the intern, myself, to question my professional confidence in effectiveness and comfortability. I reflected on my biases and preconceptions of both myself and the client. This leads into social justice. So a focus on equal treatment, removing barriers based on age, education, and socioeconomic factors. This is huge for upholding values of social justice. And then cultural and social identity, the client's values, language level, and socioeconomic status in its influence on the chosen approach and interventions. As we're looking at human diversity and social justice, We should be also looking at barriers in assessment. So the client's education level and influence on comprehension of therapeutic language presented a barrier in this case, and then oppression and marginalization. The client's childhood experiences of abuse and oppression and marginalization due to lack of access to neurological care in this case, and then social and economic justice. I played a role in advocacy for cost-effective treatment in connection to legal resources for injury reparations due to the client's accident that he was involved in. So this all comes together to support the overall accessibility and equity of this case. The last part of the reflective synthesis focuses on a social policy issue. So the policy that I chose to focus on here was the Affordable Care Act. The Affordable Care Act, or the ACA, was enacted in 2010 to expand health insurance coverage. Medicaid expansion aimed at providing accessibility to health insurance for mental health and substance use treatment. That's sort of what the Medicaid Expansion Act did. And then this policy issue arose during the client's application process for Medicaid and Medicaid expansion services. The client ran into many barriers during the application process. So despite the policy's intention, the application process presented accessibility issues and other inadequacies that we're going to continue to explore. So how can this policy be improved, the Affordable Care Act and Medicaid? Based on the barriers that I encountered with my client, there needs to be a simplified application process, increased Medicaid representation at a community level. There was a shortage of Medicaid experts in the area, and support for older populations. Elders don't have the ability to navigate nuanced technologies to complete these online applications. And then feedback and transparency. There needs to be more availability of feedback for Medicaid services through community level health, behavioral health clinics and health services. So what interventions did I apply to the case in the event of this policy issue? So through the Medicaid application process, I created brochures outlining necessary steps and documentation for Medicaid applications, and then advocacy to connect the client with community resources through connecting the client to Medicaid experts in the community. And then resource accessibility challenges. I worked with the client to help him to redistribute financial resources to facilitate a trip to the Medicaid representative. So the Medicaid representative for the client's community was a far distance and he couldn't afford the drive. So I helped to get the client connected with some community connection resources to pay some of his other bills so that he could redistribute the resources to pay for that drive. And then I developed travel plans to account for the client's physical symptoms such as headaches and stiffness. This involved making a plan for the client to make stops just to get out and stretch on the trip because it was an over an hour drive. And the client would often get stiff and get headaches from driving for long periods. So the client would get out, walk around. And then we partnered with a local nonprofit to connect Mr. Sawyer with that Medicaid expert to assist with the application, because due to limitations of my role at the agency, I wasn't allowed to help Mr. Sawyer complete that application. So I found community connections to fulfill that need. So what were the results of my interventions during this policy issue? So these interventions were successful in removing barriers and increasing Medicaid accessibility for the client. When I was unable to advocate for the client, I found community expert support to do that advocacy on my part. And then um, my interventions were guided by evidence-based practices, involvement and supervision with the LCSW, and informed by ethical standards and practices. And then, even though I could not change this policy issue at a macro level, I facilitated interventions at a micro and meso level to improve overall accessibility for my client. So, how did the agency's specific policies regarding Medicaid come into play during this policy issue? So the agency had restrictions on assisting Medicaid applications due to agency policies regarding conflicts of interest. So the agency did support my creative approaches of community collaboration, use of external experts, and advocacy at a meso and micro level. And then supervision and ethical standards came into play here. I worked closely with the agency's LCSW to ensure advocacy and interventions adhered to ethical standards regarding cultural competence and professionalism. So this slide, we're going to be talking about my learning stretch in this case. So how did this case improve my competence and improve me as a MSW? So at the beginning of my placement at a behavioral health clinic, I was lacking competence in community collaboration and assessment skills. My strengths at the beginning were in therapeutic rapport building, evidence-based intervention application, and case conceptualization. The current case introduced significant challenges regarding overcoming policy barriers, ethical dilemmas, and understanding agency assessment procedures. By the end of my placement, I was able to demonstrate the ability to engage client motivation, assess presenting problems and symptoms, conceptualize and apply evidence-based interventions, reflect on the impact of policies at a micro, meso, and macro level, utilize supervision and consultation in ethical dilemmas, and demonstrate ethical practices through the integration of cultural competence and application of interventions to support client needs regarding human diversity and social justice. To conclude my capstone presentation, my multidimensional and multidisciplinary approach was effective in facilitating progress through addressing post-secondary symptoms of traumatic brain injury. Through employing a biopsychosocial model in real time, I was able to integrate behavioral interventions with a strengths-based holistic approach to treating the client's complex mental health conditions. I fostered a therapeutic alliance through empathy, cultural competence, and advocacy. I overcame challenges such as ethical dilemmas, resource scarcity, and client barriers. Standardized screeners and evidence-based practices supported the mitigation of client anxiety, anger, loneliness, and emotional reactivity. So this case really highlights the effectiveness of using a comprehensive ecological framework and demonstrates the critical role of social workers in advocating for clients and promoting psychological, emotional, and social well-being. The next 11 slides are my references for the current presentation. So I'm just going to go through each slide and allow enough time for viewers to pause and read through my references. So this is my last reference page. I just want to thank anyone who watched this presentation, and I look forward to hearing your feedback.